morning. Good morning. Good morning, Das.
Das are
मॉर्निंग
also
सर
connected,
सर
sir.
ये तो आपका फोटे हैं सर, आपको लेना है।
नहीं नहीं नहीं, आज का आप करो क्योंकि मैं बीच में आई हैव टू आई एम एट होम, सो आई विल बी लीविंग फॉर द हॉस्पिटल, सो आई विल कंटिन्यू टू जॉइन इन द कार, बट यू कंटिन्यू प्लीज. I think Anand has not joined us yet, but since we are already at 8 o'clock, if you agree,
Sir,
we can
I have
start.
joined, sir.
नहीं नहीं, ही
He
हैज
just
जॉइंड, ही
अच्छा,
हैज
आनंद
जॉइनड
है.
बिफोर मी।
ओके ओके.
yes,
ठीक
yes.
है, स्टार्ट कराओ आनंद फिर.
चलो।
स्टार्ट. या
Yes, sir. Basel, we can start now, sir.
यस।
Yeah, but before Niranjan starts, let me introduce Dr. Das. Dr. Das is my former fellow and colleague from SCPGI Lucknow, and currently he is the professor of GI surgery at the prestigious All India Institute of Medical Sciences in New Delhi. Uh, okay, over to you, Das, please. निरंजन, आप अनम्यूट कर लो.
तो निरंजन, इज दिस द सेम केस दैट वी डिस्कस्ड लास्ट टाइम लॉन्ग बैक?
निरंजन, यू आर म्यूटेड. अनम्यूट करो.
Yes.
यस.
Sir, can you hear me now, sir?
Yes, I can hear you, Niranjan. Last time we discussed this case, the same case.
Yes, sir. Yes, sir.
So this is how many days since we discussed that one?
Sir, we had discussed it in July, sir. So it's been 3 months almost.
3 months. Okay.
Yes, sir.
Okay. So we will be discussing the situation 3 months back and now. So let's see from where we actually ended last time. You summarize up to that.
Yes, sir.
So if I remember correctly, and I was going through the presentations last time. So this is the summary. There was a 40-year-old male who was operated after a history of acute cholecystitis and gallstone disease,
Yes, sir.
and there was post-op bile leak,
Yes, sir.
but he was discharged, and
Yes,
then
sir.
he came back with collection,
Yes, sir.
and the re-laparoscopy was done. He returned back and again had problem of distension, collections, and peritonitis, and was referred to you
Yes,
after
sir.
15 days.
Yes, sir.
Okay. At that time, his LFTs were apparently normal.
Yes, sir.
Uh, Before he was referred to you, or just immediately after he was referred to you?
Yes, sir.
Okay. Now, then, in that situation, what ideal thing you should have done, or you did it?
Sir, so the patient presented with me to me with the complaints of abdominal distension, pain, and fever with chills.
Sorry, did he have
He
any medical risk factors?
Sir, no, sir. He did not have any medical risk
No
factors.
medical risk factors. Okay.
No, sir.
So he presented you, as we discussed last time, with evidence of distension abdomen, tenderness of the abdomen,
Yes, sir.
collection in the abdomen, and jaundice. Is that?
Yes, sir. Yes, sir.
Yes. So after that, what did you do?
Sir, after that, general physical examination we have to discuss, sir.
Yes.
So basically, patient came to me in, I mean, he came with an acute bile duct injury. So he came with a intra-abdominal collection. So we have evaluated the patient initially. We have done general physical examination in which we found him to have slight features of peritonitis. Actually, he had already undergone laparoscopic drain placement and lavage for the collection, but probably the drain was not adequately draining well, which is why he had slight features of peritonitis. Also, he had shortness of breath, and probably an associated effusion was also there. So yeah, so he presented to us with shortness of breath and abdominal distension and acute abdomen kind of a picture. So he was febrile also when he came. So I'll continue with the from general physical examination, sir.
Yes.
Yeah. My patient is a young gentleman who's averagely built and averagely nourished. He's dehydrated and lying in the bed. His height was 160 centimeters, weight is 78 kgs, and BMI is 23.5 kg per meter square. Heart rate is 118 beats per minute, BP 100 by 60 millimeters of mercury, and SpO2 92% on room air. Respiratory rate is about 26 cycles per minute. He's currently febrile with a temperature of 101.3 degrees Fahrenheit. Pallor is present. There is no icterus, however. Bilateral pedal edema is present, and there are no peripheral signs of chronic liver disease.
And the drain was there.
Sir, yes, sir. The drain was in situ.
So what was the drain draining?
The drain was draining about greenish bile, greenish yellow bile.
So what was that? Was it hepatic bile, gallbladder bile, duodenal bile?
Sir, it was hepatic bile.
The hepatic bile is golden yellow.
Yes, sir. It was slightly turbid, actually, sir.
Hmm. Okay, so any evidence that there was a duodenal injury from the symptoms of the examination of the drain?
Sir, duodenal injury. There are no symptoms or signs per se directly guiding me towards duodenal injury.
How did you know from the history or
Sir,
the examination?
the patient has presented to me after a month. So it was a long duration for duodenal. The patient still. I cannot completely rule out duodenal injury at this moment. Because patient has also undergone re-exploration wherein a laparoscopic lavage and drain placement was done. So an additional injury can also happen at that particular time. So I'm not very confident at this point to rule
That is
out.
okay. That is okay. But how did you, any simple test by which you know whether there is food material or not?
Yes, sir.
Could be
Yes, sir.
minor injury.
Yes, sir. Yes, sir. If there is any food, there was no food material per se in the drain. So that, and if I had to do a test, I can do a simple bedside test. Like I can give a gentian methylene blue, and I can check the drain
Or,
whether.
or you can send the contents for vegetable fibers.
Yes, sir. I can send. Yes, sir. Also, I
Okay.
can do drain fluid amylase level if the amylase
हाँ
levels
मैंने
are
नोट भी
elevated.
कहा था बट थोड़ा पहले भी भेज सकते हैं 8:30 पौने 9 तक.
Continue.
Yes, sir.
Hmm. So how do you know that the bile leak was significant?
Sir, the bile.
Any biochemical tests to say that the bile leak is significant, be it here, be it post-operative.
Uh, Sir, any
By
amount of
examining the
bile.
drain fluid, how can you say that there is a significant bile leak if a
Uh,
plus minus? So do
Sir,
you do a drain fluid bill? It
uh,
should be 3 times more than the syrup.
okay, sir.
Hmm. So in this situation, you've done the general physical examination. So what does it appear? The possibly the patient is in sepsis.
Yes, sir.
Okay. And what is the cause of the anemia?
Sir, patient has been operated twice. He has undergone. He's having on and off symptoms of. He's nutritionally a little not well. To do since a month. Also, probably patient has had a bile duct injury, so maybe there could have had been some intraoperative blood loss which can cause anemia in this patient.
Then you should have given the history whether he was taking food or he was passing motions normally, what is the color of the stool. These two things are also equally important, whether not necessary that they have bile duct injury or bile leak and they will remain fasting. Though some of these people would say that we don't feel like eating, feel like distension of the abdomen. So he had already a long course. So this could be nutritional, this could be blood loss, but that would be one-time affair. during surgery. He was already 15 days following that blood loss. There no history like that. Why should he have blood loss just for a diagnostic laparoscopy? So most probably nutritional. So his intake was important. What are the causes of nutritional deficiency in bile injury, bile duct injury, or by biliary fistula?
Sir, patient biliary fistulas or active bile leak post bile duct injury are nutritionally compromised because they might have associated biliary peritonitis or sepsis, which can cause malnutrition or loss of appetite in such patients.
That is one, but suppose that is not there, you have drained, no more peritonitis is there, will they have a nutritional deficiency?
No, sir. Also, bile itself helps in absorption of many fat-soluble vitamins, and a loss of bile in the external biliary fistulae also can cause nutritional compromise on the patient.
How? That is what I am asking. One, they decrease the absorption of the fat. So fat nutrient is gone. They decrease four vitamins. So that vitamin deficiency is there. And then bile itself it contains protein.
Yes, sir.
So and peptides. So the loss of that also causes lack of nutrients. On the top of that, if the intake is poor, obviously they are not in a good psychological shape. The abdomen is not settled. So obviously that has an effect on their nutritional status. Apart from that, they have electrolyte deficiency also.
Yes, sir.
Okay, water and electrolyte disorders. So in this situation, what was your plan and what did you do?
Um, Sir, the drain was not draining well, sir. So first, I would like to get an ultrasound of the patient.
Tell us what did you do?
Sir, first I have admitted the patient and resuscitated the patient as patient was dehydrated.
Okay,
Uh,
first step is resuscitation. You did resuscitation. Second step,
Sir, I have admitted the patient in ICU to monitor vitals, uh, uh, and after that I have gotten a ultrasound done for him to check whether there is any obvious residual collection which is not being drained, so as to place a additional percutaneous drainage tube. Also,
so
I've
you did
gotten
an
a check.
ultrasound. What was the features of the ultrasound?
Sir, ultrasound showed collection, sir. I'll just share the ultrasound report. Yeah. So, ultrasound showed mild free fluid in the Morrison's pouch, perisplenic region in the pelvis, with maximum vertical pocket of 4 centimeters, 4.2 centimeters.
This one, I think you also presented last time, this ultrasound, isn't it?
Yes, sir. Yes, sir.
Yeah, is ultrasound enough or you should do a CT scan?
Sir, I
More
can do
drainage.
uh, sir, I can do a CT scan also.
No, we can do many things. Now, whether you should do or you should manage with the ultrasound.
Uh, Sir, we can manage with ultrasound, sir.
What are the areas? What are the problems of ultrasound?
Sir,
There are certain problems. No,
yes,
what
sir.
if when the
Yes, sir.
patient is in peritonitis, when the patient you do not know from where things are leaking, duodenum, whether what are the collections which cannot be drained by ultrasound method?
Yes, sir.
Well,
So,
what are the collections?
sir, because the patient is also having abdominal distension, the
No,
bowel loops.
what are the collections that cannot be drained by ultrasound? It's very difficult to drain. It is those which are interloop collections.
Interloop.
And you cannot actually in a state of tender abdomen to move the ultrasound probe all over it, it becomes difficult. You can do it, you can grossly find, but you cannot really exclude all types of collections. One way, yes, you can manage, but you have the facility and you can do it, better to have a CT scan and see exactly where the collections are. Because some of them might be needing a CT guided. Plus, it can show other injuries. What other injuries?
Other injuries such as transverse colon injury, colonic injuries, duodenal injuries, and any major vascular injuries can also be ruled out using a CT
Yes.
scan
Yes, and you can also see the status of the liver.
and status of the liver. Yes.
Okay. So, so did you do a CT scan or you manage like this? If you
Sir,
manage like this, it's okay.
Sir, actually, patient had already done a CT scan outside. So he had come with to us with a CT angio report, sir. Uh,
No, no,
yeah.
no.
So
Go back to the ultrasound. Now you see the ultrasound.
yes, sir.
So that means anyway, you did it or the patient has come with the thing, it's okay. Now the question is, if you can manage with a ultrasound, why not redo the laparoscopy and see everything again? Why should you go for an ultrasound and just manage this if you don't want to do a CT scan on this? Now that is all right, but why don't you go for a re-laparoscopy and see yourself everything rather than going for and wash out whatever is there, put a drain. Why should you do a ultrasound? Because there are many things which you cannot really on just see doing a laparoscopy, see inside the abdomen and manage, particularly when there are sloughs everywhere and collections, color change. How can you know the vascular injuries?
Yes, sir.
And at least how there could be small bowel injury which you may miss while doing a re-laparoscopy. So these are roadmaps or guidances which will help you in manner. Already one person has done it, he was done it again, still it is not. So if you do it again, you might be committing the same mistakes that the person did. Now, in this ultrasound, if you see, I saw last time the liver was enlarged. Why it was enlarged?
Sir, probably because of cholestasis.
There was external biliary fistula, cholestasis, why it will occur. So most probably that was because of infection or maybe some amount of cholangitis inside. So that could be one of the causes because or undrained collection if it is undrained system it is if it is there it can cause but that would cause a localized atrophy more often than causing a diffuse liver enlargement. Hmm? And if there is a vascular injury, there will not be a liver enlargement, rather, that would be a atrophy, hypertrophy complex situation there. Why the spleen is enlarged?
Sir, patient can have uh,
See, at this point of time, within short period of time, biliary injuries can lead to portal
loss.
hypertension in later stage and cause a splenic enlargement or maybe portal venous injury, the thrombosis that is leading to there. This is where again the CT scan is important to tell you why spleen was enlarged, or the patient has an inherent problem with him for which spleen has been enlarged. You have to remember, and maybe it is observer dependent, it's a wrong report. That could be okay. So this is where another where again the CT would be helpful to you. And there was mild free fluid in Morrison's pouch here and there. So there seems to be not much of a collection. Then what did you do?
Sir,
So what was happening then? What was happening if there was not much of collection? And why the patient was having problem?
sir, I would like to investigate this patient further with
Now,
a
what are the possibilities
um,
of a tender abdomen where you don't find not much of a collection?
sir. Um, probably the drain is not draining well and some kind of collection has been missed.
You have the ultrasound abdomen. After
Yes, sir.
this, what are the possibilities? One is there is interloop fluid which the ultrasound has failed to. The small bowel surface is a huge surface, and this bile covers that surface and forms a slough type thing or a coagulum type thing. So that may not show you exactly the amount of collection. This is again where the CT scan is important. Okay, so one is the ultrasound has missed interloop collections or small collection diffusely present all over the abdomen, or there is a peritonitis that whatever bile is there or the coagulum is there that has got infected, or he has a cholangitis. So all
Yes,
this could contribute to this, and maybe small bowel or duodenal micropurse that could be causing the peritonitis, chemical peritonitis. These are the possibilities. And then what happens? Then what did you do final? And then he came with a CT scan, isn't it?
yes, sir.
Okay. So what are the features of the CT scan?
Sir, a CT angio had been done outside.
Why a
Uh,
chest X-ray was done?
Sir, patient had shortness of breath, sir. So we had gotten a chest X-ray done.
But you didn't say that in your presentation.
Yes, sir. No,
You said
I
okay. Oh no,
uh,
no, just tell me. I might have missed. Say yes. Yes,
yes,
yes. Pain,
oh,
shortness of breath. Okay.
yes, yes,
Hmm.
sir.
So you did his chest X-ray. What was that?
Yes, sir. The chest X-ray we got it done, and it was essentially normal. I mean, there was no obvious effusion of any sort.
Do you think this is a good exposure?
No, sir. Actually, the X-ray quality is not very good.
No, quality
Uh,
is good, but something is not good. I think this is a X-ray taken in a supine posture. That's why
yes,
the diaphragms have got up, and they have very little of the chest long fields that you are able to see. So I would, and here you can see itself. This person looks very marasmic type thing. The muscle mass is practically not visible. He has run down, and the abdomen is filled up with fluid. It's all hazy below the diaphragm that I can get. And uh, beyond that, I can't feel it. And I can see the trachea is deviated to the right side. So that shows a possibly a positional problem with the patient, which they have taken. Nothing can be commented from this. Um, so what you expect is possibly he has a collection with diaphragmatic elevation and compromise of the chest cavity. That is one, or peritonitis, which he is afraid of taking breathing, or there are chest pneumonitis. Was he really moving out of the bed? No.
no, sir.
Okay. So then you have a CT scan. What did that show?
Sir, the CT angio was done, and it was done outside.
You can straightway go to the pictures and describe.
Sir, actually, we do not have the films of the CT
Okay. Okay.
angio, but we got an MRCP of this patient in the repeat setting, like when patient
No,
came for follow-up.
but why didn't you get the picture of the CT angio? CT angio, it's they provide the CD, they provide the films. What
Uh,
was actually the problem, which I am unable to digest?
for CT angio, sir.
Yes, why? Why didn't you get the film?
Sir, we did not get the film from the patient, sir. Like the patient have to submit the films back while getting discharged. They just get the report, is what they told from the hospital where he had been discharged from.
No, these are practical problems. Sometimes they are bounded by this insurance thing for which they have to deposit all these things. But
Deposit.
still, you can get and should make all efforts to get the CD and see yourself rather than believing this one. the radiologist report, because we are also, the surgeon is also intelligent enough to radiate, see it from his point of view. So what were the significant findings from CT angio?
Sir, the
Would you
CT
do a
angio,
CCT or a CT angio or what?
sir, I would have had done a CCT, sir.
What is the difference between CCT and
So,
CT angio?
sir, in CT angio, we'll see the arterial anatomy. I mean, if there is any particular arterial injury associated, but CCT, along with oral contrasting, can rule out duodenal injury, or a rectal contrast can rule out a bowel injury. Associated injuries can be well seen on CCT, sir.
Yes. So in CCT, the only added advantage of CCT is oral contrast. Otherwise, you can see everything what you can see in CCT in CT angio. Um, Suppose you have to see only the so the collections. What type of CT you do? So you would avoid a contrast in those cases. Just if you,
Non-contrast.
as a follow-up CT, suppose after this again you need to see, or in post-operative periods you are strongly suspecting collection, nothing else, just to say why to give a contrast and exposure. So just do a plain CT, and otherwise the contrast can overshadow the collections and not give you a proper information. So you did a CT angio. So is the CT angio different from a triple phase CT?
Is the CT, sorry, sir?
CT angio different from a triphasic CT?
Yes, sir. So CT angio will just tell us about the arterial phase of the uh, uh, arterial phase, but in triple phase we will see early. I mean, we'll see the three phases, sir. We'll see the portal venous phase also, arterial phase also, and venous phase also.
You can't do that in CT angio.
Sir, we have
You can extend
we have
that one to
we
see
can.
that one also. Not that you have to see artery in one CT and then vein another CT. You can obtain all the information. The only thing is you have to inform the
Fine.
radiologist.
Yes,
You have
sir.
to inform the radiologist that I am to see all these things. Suppose the patient is bleeding, and I am strongly suspecting arterial problem, or just tell them do a CT angio, and guided by that, I would go for a direct angio. Okay, so you can see. So the thing is, this is a multidisciplinary approach, isn't it? Between the surgeons, the gastroenterologists, the radiologists, and even the microbiologists. So you have to tell them, take it into confidence, your team, and then discuss that I need this. It helps a lot. So what are the important findings you found from CT angio?
Sir, on CT angio, we found that there was no essential uh, major vascular injury seen.
Okay, and collections?
There were no collection also which was seen.
Yeah, you should not write no ascites. Ascites, free fluid, collection are the three different things. Okay,
Yes, sir.
so no collection seen. Okay, then what did you do? The CT angio has seen the veins. See,
Yes, sir.
it's not for arteries only.
Yes.
Okay, so what did you do then?
Sir, we have admitted the patient, sir. After admission, we have thoroughly resuscitated the patient with IV fluid. We have started the nutrition of the patient, and we have provided nutrition to the
You
patient.
started means orally, or you put in nasogastric?
Sir, initially we had put the nasogastric tube because patient had abdominal distension. We gave him IV fluid support along with electrolyte replenishment. After the abdominal distension came down, after the we placed an additional PCD to drain the residual collection which was there. Image guided PCD we have put. After that, patient's symptoms came down. He became afebrile and the abdominal distension came down, after which we have initiated oral feed to the patient. Along with oral feed, bile which was draining, we had sent a bile culture when the patient came. Um, so the bile was infected initially. We have given appropriate antibiotics according to the cultures. Initially, we started with piperacillin tazobactam.
And a blood culture. Okay.
And yes, sir, we have done a blood culture as well, sir. After 48 hours, we've changed the antibiotic from piperacillin tazobactam to meropenem because it was
So
resistant.
you started nutrition, you
Yes, sir.
started IV fluid replacement, you
Yes,
started
sir.
antibiotics, you put a
Yes, sir.
drain, and the
Then,
drain was draining what?
sir, it was draining bile, sir.
How much?
Around as soon as we put the percutaneous drainage tube, it drained around 500 ml, sir.
Then how much it is draining?
Then serially it has come down from 500 over a period of time. It has come down from 500 to 300 and then 300 to around 50 ml, sir.
Okay. So the over a period means how much? How many days?
Sir, we were weekly. Initially, we were following the patient after discharge. We were following the patient weekly for about 2 weeks. After that, we have followed him
Okay.
every
What
fortnight.
what could have happened within this 2 week period?
Sir, I'm suspect. Sir,
Apart from this recovery phase, what could have gone wrong during this period? What could have done wrong?
um,
One is there is no relief in peritonitis.
yes,
Then
sir.
what you would have done?
Sir, if there is no relief in peritonitis, still, I would like to see the cause for see the cause for peritonitis. So I would have had gotten an additional CCT of the abdomen.
In all probability, you'll find another collection to drain it, or you find small collections, and the solution is you could have gone for a re-laparoscopy.
Re-laparoscopic.
Okay.
Yes. Yes,
So
sir.
that is one, and also you have to find it out whether the patient was having cholangitis or not, no cholangitis.
Yes,
So
sir.
you have to look for the liver function test.
Yes, sir.
So what was the liver function test? The parameters were normal or abnormal?
Sir, the liver function test parameters were normal, sir.
So it was normal. The bile, the drain was not draining, and liver function test normal means where the bile was going.
Sir, the bile was draining. Sir, there could have been an there could have been a lateral injury only, which the biliary continuity was still there.
Yeah,
So,
but the drain was not draining. So that could be some collection still happening, which we do not know.
mm,
And another thing is it might take a little bit time to derange everything, not necessarily that immediately it will have. So in that case, anything else you need to do? Is there any role of a HIDA scan here?
sir, we can do a HIDA scan in such cases.
No, we
Wherein
can. What should I do?
it will, yes, sir.
If
It
you
will
see,
rule out.
it is not a must in this particular situation, but if you have the facility, you can have some idea whether small trickling is happening into the abdomen or not. Plus, they will show you biliary continuity is there or not, provided the output is not very high. So if the output is high, they preferentially the activity will go there. They won't go down. So there is a small indication, but not necessarily that it has to be done. More often than not, they're now used as a follow-up procedure rather than the guiding you for the treatment, particularly when you have the MRCP for a better guidance. Anyway, you have to do. Okay. Now that is one scenario. Second, suppose this patient shows bleeding to the drain. Is there a possibility?
Bleeding through the drain. Yes, sir, there is a possibility.
From where it can come?
Sir, there can be an partial vascular injury, which has led to an aneurysm, and the aneurysm has started bleeding.
It could be injury which has sealed off, now had to open up, even from the venous blade, bleeding from the liver bed, which is less usual. So in those cases, it could be, if it is still prolonged, it could be from the granulation tissue. So
Yes.
then in those cases, you need to tackle them radiologically if it is possible.
Yes, sir.
Okay. So these are some of the happenings that can occur. Now, you didn't mention about the histopathology. Okay. Suppose the histopathology shows that it is a case of incidental gallbladder malignancy.
Yes, sir.
Now, the situation is like this. What would you do?
Sir, incidental CAGB with bile duct injury, it's like double trouble, sir. Actually, I would like to see the on histopathology. I would like to see the stage as well and the completion of the surgery. I mean, if it is just a T1A kind of a lesion where only the mucosa is involved, maybe I can just laparoscopic
T2,
cholecystectomy.
T2, T2, incidental gallbladder malignancy with biliary fistula.
Sir, I would like to wait,
Which
sir,
which
for
is important, so far as the time is concerned.
sir, gallbladder malignancies are rapidly.
Malignancies is concerned. So
Yes,
there, see, though the literature is not very clear on this,
yes,
that it is prudent to say that if you can go in within that stipulated period, which is the best period to go for IGVC, with the
sir,
best time to go for the extended cholecystectomy.
sir, 4 weeks, sir, around 4 weeks.
4 to 8 weeks is the
Four
period.
weeks.
If you do before that, it is not good. The results were not good. There reasons for that. If it is after, again the results are not good. So within this golden, up to this golden period, you can wait, and then you have to take a call what exactly you have to do. But you have to do it, isn't
Yes,
it?
sir.
You have to do it. You have to take a risk of doing a surgery for the gallbladder cancer as well as the biliary tract.
Yes, sir.
Okay, so after this, this is almost going to stop. The drain is going to stop soon. What happened over this 3 months period?
So, sir, the drain output gradually reduced from 500
We,
to
we, we expect that the patient would develop jaundice, isn't it?
yes, sir.
And there would have been a stricture
Yes, sir.
with or without a small fistula.
Yes, sir.
Okay, and we have excluded a duodenal or bowel injury.
Yes, sir.
Now, at this stage, what would we do?
Sir,
Now this is 4 months, for 5 months. June, you said the June. I think the injury was there, if I remember
yes, sir.
correctly.
Yes, sir.
So on July, August, September, 3 months.
Yes. Yes, sir.
July, August, September. Yes.
Yes, sir.
So now
So,
what to do? Now what has happened over this period? Is the patient recovered so far as the nutrition is concerned? The sepsis is controlled or not?
yes, sir. The sepsis was controlled, sir. Patient
Mhm.
has recovered nutritionally as well,
Mhm.
and we have
Is
to
he
plan.
is he passing colored stools?
Yes, sir. He is passing normal colored stools as well,
How?
sir. There is an associated fistula, sir, small fistula,
So you
which
mean
is
to say there was a lateral fistula, and which has formed a separate tract
track.
and
Yes, sir.
going into the duodenum.
Yes, sir. Yes, sir.
Through what hole it will go to the duodenum? Don't you said there was no injury in the duodenum?
No, sir. There was no injury in the duodenum, but eventually, over the period of over the period of time, a spontaneous fistula had developed. A tract had formed. Um
So how did you document that tract? What are the methods to document the tract? One is a nuclear scan.
Yes, sir.
Second, can you document it from the MRI, MRCP?
We can document it from the MR also, sir. MRCP also.
What MRCP?
Sir, we can we will
Have you
see the,
documented? Do you have the picture of that documentation?
we have, again, MRI was also done outside, sir. So I
Hmm.
have the film of MRCP.
Hmm. Tell me show me important findings.
Sir, we can see the dilated system, sir.
Tell me the order in which you should see the MRCP, MRI in a case of biliary stricture or injury.
Sir, first, livers, we have to comment about the intrahepatic biliary radicals,
What
whether
is
they
the prerequisite for a MRI, MRCP? That should not have happened, or that is not there, then only I'll do MRI.
sir, patient should be dry. I mean, there should be no collection, sir.
No collection. That is one of the, because that collection would what?
It will obscure. I mean, it will not delineate the biliary tract anatomy well.
So what images you would like to see in case of biliary injury? T1 or T2?
Sir, I like to see T2 images, sir.
Why? Why in T1 what do you see best? T2 what do you see best?
Sir, in T2, I'll be able to see the, I mean, bile will act as a natural, I mean, it will act like a contrast. So I will be able to delineate the biliary anatomy well on
T1
T2 image.
images are fat savvy.
Fat suppressed,
Can
yes.
denote the fats very well. T2 are more water savvy. So
Yes,
they
sir.
can see the liquids. That is what is a type of MRI called dynamic MRI. That's what I was asking about, finding a lateral track. So you can find them. You see T2 images. You must know also what is T1, why it is called T1, why it is called T2 from examination point of view. So here I would like to see collections, whether actually I had missed. Then is it a contrast enhanced or a plain MRI? What should you do? You should do a contrast enhanced.
Contrast enhanced, yes, sir.
So I would like to see status of the liver first.
Yes, sir. Yes,
What
yes.
was the liver is normal? You said it was 14 centimeter, and is it enlarged or shrunken or what?
It was slightly enlarged, sir. 16 centimeters it was.
Okay, what about the what are the parenchyma?
So the parenchyma was normal. Slight cholestatic picture was there,
Hmm.
but no cholangular abscesses or anything of that sort was seen.
So there were no cholangular abscess. Can you say whether the bile ducts are inflamed or not from MRI? Yes, you can say, but that has to be in the T2
T2.
imaging phase. You can see the cholangitis. Mostly T2 shows you inflammation. Okay, you definitely know, you can know about the portal venous radicals, whether the walls are thickened, thrombosis is there or not, arterial anatomy, and atrophy hypertrophy
Yes, sir.
problem. Okay. How many days of biliary injury, atrophy hypertrophy complex will occur?
Sir, it will take around 6 months, sir.
Start. It's just you have to follow the portal vein embolization procedure.
Yes, sir.
So as early as 6 weeks
Six
or even
weeks.
3 weeks. Portal vein embolization, when do you get the hypertrophy? You can get it as early as 10 days, 15 days. Okay. So that is important. The portal vein anatomy is important because ultimately it has to guide you during surgery, whether it is running in front, back, how close it is, how close the artery is at the hilum. Those are the things which are important. And then other visceras, what are the situations? And finally, you have to have a MRCP. Okay, so was the MRCP.
Yes, sir.
Can you get a cirrhosis at this stage?
No, sir. It is early for cirrhosis, sir. Cirrhosis will take generally around 6 months to develop.
Yeah, it usually takes 6 months, but earlier on, by definition, they were saying 2 years. But as early as 6 months, even 3 months also described, but 6 months to be precise.
Yes, sir.
MRCP shows the MRCP.
Yes, sir.
So if you have done a MRCP a
Yes, sir.
month back,
Yes, sir.
is it necessary to do another MRCP now, or it will do?
Sir, when we are planning a definitive management, we need to see the level of stricture. So,
That we have done a month back. What I'm asking is, what should be the gap between two MRCPs to give you a change in findings? So it all maybe a month back you had a biliary injury and a biliary fistula. Now it could have ended up in a stricture. Or there was a stricture setting in, now it has become complete.
yes, sir.
Or there was atrophy, hypertrophy, not there, now it will become obvious. The gap is ideally should be 6 weeks, but it is nothing like that. No hard and fast rule. It all depends upon what you are suspecting on the basis of ultrasound.
Yes, sir.
Okay, so a good ultrasound is very important. Good means the resolution as well as your radiologist.
Yes, sir.
MRCP just show us the static picture. You have a projectional MRCP.
No, sir. Actually, this
Okay,
MRCP was done
okay.
outside only, but I have ordered the video from the technician who was
So
available.
do you have a projectional picture? Or tell me from this cut transfer sections, what are the type of structure?
Sir,
Quickly show me the dots.
yes, sir.
The best way to describe a structure is just follow all the dots.
Yes, sir.
The hilum.
Yes, sir. The hilum, we can see the hilum being formed, sir. There is just,
Show me segment 2. What is this you are saying? Is it biliary or it is?
it is,
What is this? This is biliary or this is vascular?
sir, this is biliary, sir.
Why not? Why not hepatic veins? Why not portal vein? It is by the configuration and the sections where we are taking.
Yes, sir.
So that is why a running examination is needed. You come down from the heart downwards. First, you will encounter the hepatic veins.
Yes, sir.
Second is their intrahepatic configuration. The portal vein runs straight vertically and then divides, and the walls are a little bit thicker than hepatic veins. In hepatic veins, the configuration they come from all three sides and join. And finally, you find the biliary ductal anatomy, which is completely different, and just would be alongside of the portal veins. But the wall thickness, the narrowing which goes to the periphery, the formation at the center, and enhancement, all these would differentiate between the two from these transfer sections.
Yes, sir.
Okay. So what is the, I'm actually not able to comment on this. The pictures, they're not of good quality. So what was the report? It was what type of structure?
Sir, they have reported it as a non-visualization of approximately 13 of proximal common bile duct in the operative bed with surrounding inflammation. So they have given it
You
as,
answer me. I'm asking from surgeon's point of view. What was the type of structure?
sir, it was E2 type of stricture, sir. Type 2 stricture. It was
It
around
was,
less than 2 centimeters from the hilum.
so it was type 2 stricture.
Yes, sir.
What was the biliary anatomy? Is it a normal type of biliary anatomy? In
Sir,
how many percentage of cases you get a normal hilum? Normal means standard hilum.
around 57% patients will
So
have
60 to 70%. And what is the next abnormality? Just the
sir,
next abnormality. That
right,
is right posterior draining
right
into the left.
posterior. Yes, sir.
And any vascular problem you found in MRI?
No, sir.
Any atrophy, hypertrophy complex?
No, sir.
Any cirrhosis?
No, sir.
And we were sure that we could find all the ducts merging, no duct is missing.
No, sir.
Okay, with that, what would you do? What is the plan now?
Sir, my plan is
Do you think the patient will become normal? Patient will recover completely or he would need intervention?
I will need intervention, sir.
If you don't intervene, what will happen?
Sir, there is a small inadequately draining fistula probably
That
into
is
the
one.
duodenum.
What if you do not treat this patient for 6 months?
Sir, their patient will probably land up in biliary cirrhosis, sir.
So you'll end up in that and also other complications like what
Yes,
we
sir.
discussed now.
Yes, sir.
So to avoid that and to maintain a biliary continuity, we have to go for surgery.
Yes,
Surgery
sir.
or not?
Yes, sir. We have to go for surgery.
Go for surgery. Any other method other than surgery in this particular case? Can you go for a PTBD dilatation?
We can try PTBD dilatation, sir.
Will it be possible?
It
Why
it
should
is
you try when you know that there is a
it
loss of
is
CBD?
yes, sir.
Trying will cause more cholangitis.
Yes, sir.
And
Yes,
also
sir.
the same thing for ERCP. If
Yes,
you
sir.
pass the guide wire, inject the contrast, and then the contrast is not coming down,
Fine.
then
Yes,
you
sir.
are introducing infection. So
Yes,
that
sir.
is your call to take. Okay, only when you have some indication from MRI, then you go for all this. Otherwise,
Yes,
no. Now you are planning for surgery. So what is the ideal time?
sir. The ideal time would be we have to wait till the patient is dry, he's out of sepsis, and he's nutritionally well built.
If it will be 1 year, will you operate after 1 year?
No, sir. I have to wait for a period of 6 weeks, sir. Af- After after that, I can
But
assess
many
and then
people will say 3 months,
3
though as
months. Yes,
early as 6 weeks is not really demanding to that. What are the conditions in which you are to go early?
sir. If the patient
Continues with sepsis,
sepsis.
or if the patient has fistula, high output fistula, making him unstable so far as the nutrition or the electrolyte balance are concerned,
Yes, sir.
or there are complications, or the patient has some medical risk factors wherein you would not like to really continue it for a long time. So you are planning a surgery. So you have opened the abdomen
Yes, sir.
after preparations. You should know what are the pre-op preparations. So after opening the abdomen, you have made the incision.
Yes,
Now
sir.
tell me the steps.
Yeah. Sir, because it was a
So
previous.
when I open the abdomen,
Yes, sir.
by what incision you will open?
Sir, I will take a right subcostal incision, sir.
Okay. So some people also prefer, if it is a higher injury, you can make a
Sure.
midline, upper
Yes.
midline extension.
Yes, sir.
And then once you open it, after 3 months, what are the possibilities you would find?
Sir, I am expecting dense adhesions, sir. The colon might be pulled up, the duodenum might be like there might be adhesions at the porta. Also, there might be adhesions of the liver with the anterior abdominal wall.
So
Uh,
what is the next step now? Suppose the liver is densely adhered to the parietes, it is very difficult to apply retractor.
yes, sir.
So what would you do?
Sir, I would like to take down the adhesions of the liver with the parietes, and then apply a self-retaining retractor.
In which
So as to
condition? In which condition you would not like to take down the liver or do a adialysis?
sir, if the liver is cholestatic and there are chances of it bleeding
No, no, no,
in
no, no. If the liver has a vascular injury, there is atrophy type thing. They tend to take vascular supply from the periphery.
periphery.
So that you have to anticipate preoperatively as well as operatively. So while dissecting the liver out of the diaphragm, if you find lot very dense and you're tearing the liver time and again, better not to do.
Better not. Yes, sir.
And that's a fixed liver, and with that you have to work. So that can be a situation. There could be situation of dense adhesion between the bowel and the liver, which you need to do adialysis
Yes,
from
sir.
right to left and left to right. So you
Yes,
have done a adialysis, applied the retractor. Before applying the retractor, you should divide the falciform liver.
yes, sir.
If you do not divide, then you tend to injure the liver because of the traction of the
Falciform.
falciform ligament. You have divided, you have applied the mop properly. You should know how to apply the mops
No.
to go into the hilum. Then you have
Yes, sir.
applied it on a good retraction, and then you are approaching the hilum.
Yes, sir.
What are the methods of identifying the duct?
Sir, we can push if there is an existing tract because of
Yes,
we have placed the
one is follow the track.
drain. Yes, sir.
So there are about 9 methods to find the duct.
Yes,
One
sir.
is follow the track.
Yes, sir.
Second,
if there is a PTC, we can do a PTC. We can do a PTC to identify the delineate the tip of the
so
PTC.
one is whether you have a preoperative PTC. We didn't discuss because of time. In which cases you put the PTC, but if you have a complex biliary stricture or with a biliary fistula, it becomes difficult. Though in these cases, doing a PTC in a trained system is difficult, requires expertise. So ideally, if you can, it is always good to have a PTC guide, which in those in during surgery you have to really inflate the PTC or PTBD, whatever they have done, well in advance before you aspirate the duct. So one is a PTC, but you should know in a protocolized manner. One is a track, one
Yes,
is
sir.
a tube,
Yes, sir.
one is a presence of sutures,
Yes, sir.
presence of clips.
Yes, sir.
Okay, and if after adialysis you can find bile streaking out from some place. Okay, and then PTC.
Yes,
And
sir.
if that is not there, PTC will not show you the duct. No, it is only will help you in aspirating. Or if it is a type 2 or type 1, you can feel the PTC. That is the only
Yes, sir.
thing. But
Yes.
that's not very helpful in finding a duct. So what else you have? You have intraoperative ultrasound.
Ultrasound. Yes, sir.
Okay. And done an ultrasound, there is a PTC, and you can mark out the duct. Or if before that also, if you need, can go from left to right,
Yes,
and
sir.
from the left approach, because left duct is usually spare, and
Yes,
then
sir.
from there you can come back and towards the hilum and see.
Yes, sir.
So you do something for that. What would you do? You should not open the duct or aspirate before doing that step. That is hilar plate down.
Down, huh? Yes,
What
sir.
is hilar plate? Hilar plate is a thickening around the ducts, the thickening of the glycerin capsule, the junction of the liver capsule, the peritoneum, and all thickening there. You have to divide that the capsule just anterior to this thickening, or down lift up the liver by using a right angle forceps. You can really, if you know how to do hilar plate downing, it becomes very easy to find a duct. So left to right, and you should know the configuration, how the segment 2 duct goes, because you have to ultimately probe them.
Yes, sir.
Once you probe, you should know whether in a 90-degree angle they are going or acute angle, obtuse angle. So hilar plate downing was one of the very important methods. And you should know the variation of the hilar plate downing. What are the variation in anatomy? The type 1 anatomy, 2, 3, like that. So you have to have that idea, because you can face anything on the operation table. You should be ready for that.
Yes.
And then suppose still we are not finding the duct, it's a drain duct. What else? So you can core around the hilar area of the liver tissue by using a QSAR. The 1 centimeter coring, just go on touching, burning, touching, burning. Some bleeding will be there, but still you can really find it out. Some people excise the quadrant lobe, segment 4, to find out that one. Okay, and the what other? And then finally you can do a hepatotomy along the Cantel's line to reach that one. That is one of the methods. Suppose this is also not possible, then it's a biliary fistula, not finding any ducts, very thin ducts. You aspirate, there is some bile coming from here and there, but not finding. So there are 2 ways. Either you can go for a portoenterostomy to start. Like you find multiple holes. Those are very, very rare conditions. We have done it in ACPGI, that's what I'm saying. And then after 1 year or so, we could find dilated ducts, and then we could go for a repair. These are only very unusual situations, not recommendations. And in worst scenarios described is go for a segment 3 bypass.
Segment 3.
Cross through the falciparum, go to the segment 3 and do that. And what is the prerequisite before opening the duct? Anand, are we approaching the time?
Yes, sir. Yes, sir. We have to finish in 5 minutes, sir.
Okay, we'll finish. So what I was asking?
Sir, what do we have to see before we?
What you have to ensure before doing a aspiration or before opening it. We have to ensure it's a good practice to see where is the hepatic artery. So if you can feel, palpate, map it out with a marker, it's fine. Or else you do your ultrasound, particularly in complex biliary injuries. What is a complex biliary injury by definition? You should know that. So this is one part. There are 3, 4 types. One is a higher injury. One is association with
vascular injury.
One association with vascular injury, association with atrophy, hypertrophy, association with cirrhosis. So the approaches are different. So you must ideally you should delineate where the course of the artery is, course of the portal vein. So in particularly atrophy, hypertrophy complex, the portal vein remains anterior. So in those cases, you should know the technique, how to go and approach the hilum, how to loop the artery, what do you do to the portal vein? Is it very easy to loop the portal vein? There are instances of portal vein injuries doing biliary stricture surgery. Okay, so now you have found out the duct, you opened the duct, and then while opening the duct, you are now to decide to go for a hepatico-jejunostomy.
Yes, sir.
So you have done you should know how much of ruling should be there. The question would be why you take 45 centimeter. Can you answer why you take 45 centimeter? ruling? Why not 30? Why not 25? Why more than 45?
45 centimeters we have to take, sir.
Why? So because see, the peristalsis in the limb is
We have
about
to
20
take.
to 25 centimeters. You have to take 2 peristalsis at least to
Yes,
prevent
sir.
bile reflux. So these are
Yes, sir.
common questions as to how much afferent limb. If you see in the book, they say 20-25 centimeter. Professor Kapoor has taught us that you should take a longer limb. And in fact, only yesterday we found a jejunostomy leak in a case of portal biliopathy, which we had done hepaticojejunostomy, re-explored. There was a jejunostomy leak. And we had taken only 20 centimeter. Very difficult to revise the anastomosis. So you're done a hepaticojejunostomy, whether you stent or you don't stent. And of course, 2 centimeter mucosa to mucosa, all those things they remain. And then whether you do a stenting or not do a stenting.
Sir, no stenting
So what does
required.
the literature say? When do you stent?
Sir, the caliber comes down if we stent, so stenting is not necessary.
So only in 2 occasions. No. You should know the literature, the Pete's article. See, there are only 2 common situations where you may put a stent to this, and you should know what type of stent. One is presence of abscess cavity at the hilum. And second is if you're not satisfied with your anastomosis, the tissue is not good. And anyway, you have a PTBD, then we would like to progress that one, advance that one into the jejunum. In any way, you have to do it. So do that. Do you do a access loop?
Sir?
Access loop.
Uh,
Know what is
no.
access loop? Access loop is the blind end of the rule that you either keep it just below the abdominal wall parietal in between the fascia to access it later on, or you join it to the stomach, the antrum, which you can access. So these are now become theoretical questions wherein if you have some possibility of ductal stones, or you think that my anastomosis is not good, is likely to have the stricture wherein I need to have a dilatation. Nowadays, of course, PTBD and dilatation is the preferred choice. But this is one just to conclude the entire thing that you have a choice for that to do access loop for dilatation later on.
Yes.
So recent literature says they have not been very useful, even if in case of hepatolithiasis or so, for dilatation. That's a Chennai group has published. Okay, so that's all.
Yes.
Thank you very much. Well presented. Thank you, Kapoor
Thank you,
sir,
sir.
and thank you, Anand. From my side, Anand, you can close with some comments.
Yes, sir.
Thank you, Das, for conducting this very educative session. Thank you very much.
Thank
Anand,
you, sir.
you can conclude.
Yes, sir. That's regarding the today's session, the important thing was the intraoperative after identification, how to identify the duct is very important, and you have told the techniques around 7 to 8 points. These are very good, sir. Otherwise, it's a very good and interactive session. Thank you, sir, for coordinating for today's session, sir. So we can close the today's
Yes.
session.
Yes,
Or
yes.
you want to
Thank
ask
you.
anything, Niranjan? Niranjan, you want to ask anything to sir?
No, sir.
Okay, that's it.
Actually, I should add something. Most of the times, I must have attended more than 10 of them sessions on biliary strictures and injuries. Most of the time, while discussing case, we used to stop just before the operative procedure. So
Yes, sir.
we should discuss the operative procedures more. Most of the time we discuss what are the problems with bile and MRI, MRCP. So very rarely you will find that people really entering into the surgical area, which is our area, which we need to know what are the how do you manage with biliovascular injuries. Suppose a person comes with biliary fistula and he has vascular injuries, then whether you reconstruct, don't reconstruct, what is the technique in secondary biliary cirrhosis, what is the technique in cirrhosis liver, all these things you should be able to answer in the exams. Okay.
Yes, sir.
Okay. Thank you very much.
Okay.
We can leave.
Okay, we are
Thanks.
closing the session. Thank you. Thank you.
Thank you, sir.